Can you show my slide?
Yes.
Yes. Okay, thank you. Okay, next I will start my presentation, diagnosis. Joan, you remember this one? Yes?
Yes.
Yes, last time I purchased in the Bangkok market for my family. Yeah,
Fine.
this is maybe this is my name. But I'm sorry, I cannot read the Thailand word.
Yes, this is the Thai language.
Okay, thank you very much. Anyway, I will start. Yeah, this is my agenda of my presentation. First of all, I will talk about the squamous cell carcinoma of the esophagus. And next is the gastric cancer, adenocarcinoma. This slide shows the annual incidence of the esophageal cancer proposed by WHO 2010. As you can see, in Japan, the squamous cell carcinoma incidence is quite high. Yeah, compared to Japan, the Thailand incidence is a little bit lower. It's maybe because of the alcohol or cigarette consumption. In Japan, the percentage of the squamous cell carcinoma is about 90%. It's quite high. And the percentage of the squamous cell carcinoma is not so decreasing recently. We imagine maybe 10 years or 20 years ago, the percentage of the adenocarcinoma is increasing rapidly in Japan, but clinical situation is not so. The percentage of the squamous cell carcinoma is now about 85 or 90% in Japan. This is a report from the Thailand. Yeah, this situation is quite similar to Japan. About 90% of the esophageal cancer is squamous cell carcinoma. But unfortunately, the squamous cell carcinoma esophagus can be detected in Thailand in advanced stage. So prognosis of the Thailand patient is not so good. Yeah, squamous cell carcinoma in the esophagus is common in Thailand. But most of the esophageal cancer is detected in advanced stage, and earlier detection of the esophageal cancer is desired. First of all, you have to know the terminology of the superficial esophageal cancer. If the superficial esophageal cancer is limited to the epithelial layer, such a cancer is called as EP or M1. If the cancer is embedded to the lamina propria, cancer is called as M2 or LPM. If the cancer is attaching to the muscularis mucosa, such cancer called as M3. This is a T1A cancer. But if the cancer is invading to the submucosal layer, but the invasion depth is less than 200 micrometers from the muscularis mucosa, such cancer is called as SM1. And if the cancer is invading to the submucosal space more than 200 micrometers from the muscularis mucosa, such cancer is called as SM2. Why we divided so strictly? The survival rate after resection is completely different. If you treat the patient in early stage intermucosal cancer, the prognosis after resection, such as esophagectomy or endoscopic treatment, is quite good. But if the cancer is embedding to the submucosal layer and SM1, SM2, SM3, a little bit deeper and deeper and deeper, the prognosis after the treatment is getting worse. So it is necessary to detect the lesion in early stage. To detect the early stage for squamous cell carcinoma, it is very important to know the risk factor of the squamous cell carcinoma. As you know, alcohol consumption and cigarette has a very high relationship to the carcinogenesis of the squamous cell carcinoma of the esophagus and the pharynx. So if you know the history of the alcohol consumption or cigarette consumption, if you face such patient, please be careful during the endoscopic observation in the pharynx and the esophagus. But maybe doctor in Thailand is very busy, and it is sometimes difficult to listen to the such consumption. And in this situation, if you find such black coloration like melanosis or hyperkeratosis in the oral cavity, these endoscopic finding has a high relationship to the squamous cell carcinoma of the esophagus and pharynx. If you find such endoscopic feature in patient oral cavity, please be careful during the endoscopic observation in the esophagus and pharynx. First of all, you should know the white light endoscopic image of the squamous cell carcinoma. First is the coloration. About over 80% of the squamous cell carcinoma is reddish. And next is the irregularity of the surface. And sometimes squamous cell carcinoma has keratosis, hyperkeratosis in the region. And such hyperkeratosis or dyskeratosis help me to detect the lesion. And next is this appearance of the background vascular network. Please check such endoscopic feature, white light endoscopic feature of the squamous cell carcinoma. And if you find such endoscopic feature, please check using the NBI. And during the endoscopic observation in the esophagus, the amount of the air is quite important. Can you find the lesion in this endoscopic image? If the esophagus is distended, the lesion is difficult to detect easily. But if you deflate slowly, the lesion located at the posterior wall can be recognized easily. And if you deflate more, the lesion can be recognized as reddish and depressed area like this. So it is very important during the endoscopic observation. The amount of the air is very important. Not too distant is important. And can you find the lesion? This lesion is located at the right side of the hypopharynx. As I told you, squamous cell carcinoma has 4 characters: coloration, irregularity, keratosis, and vascular network. But sometimes it is difficult. But in this region, coloration change and vascular network, you should detect. But sometimes it is very difficult to detect only white light imaging. But in this situation, NBI is very useful. In NBI, much more easier. Maybe you can detect the lesion as brownish area, and the vascular density of IPCL is quite high in squamous cell carcinoma. So if you detect the lesion, please check using NBI. And can you find the lesion? Yeah, compared to the white light endoscopy, in NBI, the lesion can be recognized easily because the lesion is brownish and vascular density of IPCL, yeah, such a dot-like vascular is very high density, and the lesion can be recognized easily using NBI. Please remember the name of IPCL. IPCL is intrapapillary capillary loop. IPCL is proposed by Professor Inoue. IPCL can be observed not only cancerous area, but also normal area. But in normal area, the structure and distribution of IPCL is regular. And the vascular density is low compared to cancerous area. However, if you observe the cancerous area, IPCL is changing in their morphology. And the four character is very important. Dilatation, tutorosity, caliber change, and barrier shape. This four character is very important. If you recognize these four character, you can diagnose this region as cancer. And the distribution is also important. In cancerous area, the distribution of IPCL is quite irregular. And we evaluate the vascular density using ESD specimen. We compared to vascular density between normal area and cancerous area. And the density of cancerous area is about twice as normal. This is a report from Japan of a randomized controlled trial to evaluate the detection rate of squamous cell carcinoma in the head and neck and esophagus. According to this report, NBI is much more significantly higher detection rate, especially lesion is smaller than 10 millimeter. Yeah, you can detect the lesion using NBI if the lesion is smaller than 10 millimeter. And the NBI is also high diagnostic accuracy. So in Japan, detection and diagnostic accuracy is NBI is superior to white light imaging. As I told you, compared to white light imaging, NBI is much easier to detect the lesion. But chromoendoscopy is useful, also useful for detect the lesion. If you suspect the lesion using white light imaging and NBI, finally, please spray iodine staining. The percentage of the Lugol is about 1%. Sometimes we experience such multiple iodine unstained area, like this. And sometimes we are confused. Which lesion should we take biopsy? Yeah, after spraying iodine staining, please wait 1 to 2 minutes. If you detect such multiple iodine unstained area, if the cancerous area in cancer, the tone of the lesion is changing from yellow to pink after spraying 1 to 2 minutes after spraying iodine staining. And this pink color sign is very good indicator for cancer. Yes, pink color sign is proposed by Professor Ishihara. He is a colleague of the Professor Guido. There are currently 2 magnifying endoscopic classification in Japan: Inoue's classification and Arima's classification. But recently, Japan Esophageal Society's classification is proposed to integrate 2 classification. It's very easy classification, AB classification. This is a scheme of the Japan Esophageal Society's classification. In this classification, we divide 2 types, type A and type B. Type A is normal. Yeah, as I told you, the IPCL distribution and structure is regular, and the vascular density is not so high. Type A corresponds to normal IPCL or mild inflammation. But type B has a character of dilatation, tuberosity, caliber change, and barrier shape. If you find such 4 characters, please call such vessel as type B vessel. And the type B vessel is subdivided into 3 groups: type B1, B2, and B3. B1 vessel is like this. B1 vessel is with loop-like formation. If each IPCL has loop formation, please call such vessel as type B1 vessel. And histologically, such vessel is corresponding to M1 or M2, and there is no lymph node metastasis possibility. So this cancer is indication for endoscopic treatment. But if the loop formation is destructive, such vessel has not loop formation, we call such vessel as type B2 vessel. And histologically corresponding to the M3 or SM1, and the possibility of the lymph node metastasis is about 10% to 20%. It's not so low. So this cancer is a relative indication for endoscopic treatment. But if you find such dilated vessel, this vessel should be called as type B3 vessel. B3 vessel is corresponding to deeper layer of the submucosa, SM2 cancer. So the percentage of the lymph node metastasis is about 40% or 50%. And these patients have to be treated by surgical operation with lymph node dissection. Avascular area. Please remember the name of avascular area. Avascular area proposed by Professor Ariman. Avascular area is the area surrounded by irregular microvessel like this. And Professor Ariman proposed the relationship between the size of the AVA and invasion depth. If the AVA is smaller than 500 micrometer, it corresponds to M1 or M2 cancer. If the AVA is middle is from 500 to 3000, like this. AVA middle is corresponding to M3 to SMR. And if you detect such very large AVA, these AVA should be called as AVA large, and histologically, AVA large is corresponding to SM2. And the information of AVA size is very useful for making diagnosis of the tumor depth. And this is the diagnostic accuracy of this classification. Totally, diagnostic accuracy is about 90%. It's relatively good. However, as you can see, if you find type B vessel, about 1/4 cases is misdiagnosis. The judgment of loop formation is sometimes subjective. Yes, one doctor called type B1 and the other doctor called type B2. This is the first problem. And the incidence of type B3 vessel is not so high. In SM2 cancer. So the incidence of type B3 vessel is about 50%. It is the second problem. In summary, I was talking about the risk factor of the squamous cell carcinoma. If the patient has a history of the alcohol consumption or cigarette, please check the esophagus and the pharynx very carefully using NBI. And if you find the hyperkeratosis or melanosis in the oral cavity in the patient, please check the esophagus and pharynx very carefully using NBI. And I'm talking about the endoscopic feature of the white line endoscopy and NBI and chroma endoscopy. In white line endoscopy, about 80% of the region is reddish and depressed. And sometimes the hyperkeratosis is very helpful for detection of the squamous cell carcinoma. And in NBI, most of the region can be detected as brownish area. And in the region, the vascular density of IPCL is quite high. And finally, I'm talking about the Japan Esophageal Society's classification, AB classification. Using NBI magnification, we can make diagnosis of the tumor depths with high confidence. Next, I will talk about the gastric cancer. As everybody knows, the risk factor of the gastric cancer is H. pylori. And after endoscopic resection, the metaclonus cancer after endoscopic treatment is quite important. This is a report from Dr. Abe. He belonged to National Cancer Center, Dr. Saito's institution. And he reported the cumulative metaclonus cancer rate after endoscopic treatment. And according to this report, the cumulative metaclonus cancer rate is relatively high. And but if you can find the early gastric cancer after endoscopic resection, most of the region can be treated by endoscopy. So it is very important to follow up after endoscopic examination. This is a report from our hospital. Same as Dr. Abe's report, the metaclonus cancer rate about 5 years after endoscopy resection is about 10%. It's quite high. So I think the patient after endoscopic resection of the early gastric cancer is a high-risk patient for the next early gastric cancer. So endoscopic surveillance is important after endoscopic resection. And this is a report from Japan. After endoscopic resection, the eradication of H. pylori is useful for prevent the metaclonus cancer. This is this report was reported from Japan. According to this report, the eradication after the eradication, the metaclonus cancer rate is significantly decreasing compared to the non-eradicated patient. So, Japan Gastric Cancer Association recommended the eradication of H. pylori after endoscopic treatment. First of all, we have to know the H. pylori negative and H. pylori positive endoscopic image. This slide shows the typical endoscopic image of H. pylori negative or H. pylori naive patient. If you find such linear reddish area or lack regular arrangement of collecting venue, gastric antral erosion, or fundic gland polyp, this endoscopic feature is strongly related to the H. pylori negative patient. And in the NBI magnification, in the gastric body, the capillary loop surrounded the gastric pit. So on NBI, dark area surrounded the light area in the gastric body. This is a typical NBI magnification image of the gastric body of H. pylori negative patient. And this is the endoscopic image of the gastric antrum. The endoscopic image of the NBI magnification is a little bit different from gastric antrum and gastric body. In the antrum, coiled vessels are situated on the crest of the gastric gland. So in NBI, light area surrounded the dark area. This is the typical image of the H. pylori negative patient. On the other hand, this is the typical endoscopic image of the H. pylori positive patient. Here, atrophy, xanthoma, or intestinal metaplasia. This endoscopic feature is strongly related to the H. pylori positive patient. And sometimes enlarged hole, spotty reddish area, or nodular gastritis. If you find such endoscopic feature, this patient has a high possibility of H. pylori positive. So if you find such endoscopic image in the patient, please observe very carefully during the endoscopic observation in the stomach. And this is the typical NBI image of H. pylori positive patient. The microstructure is slightly irregular compared to the H. pylori negative patient. And this fine blue-white linear structure on the crest is called light blue crest. Light blue crest is proposed by Professor Uedo. And light blue crest is strongly correlated to the intestinal metaplasia histologically. So if you find such endoscopic feature using NBI magnification, this endoscopic feature is strongly related to the intestinal metaplasia. And the intestinal metaplasia is the high relationship of the carcinogenesis of the gastric cancer. And this paper reported the relationship between atrophic grading and the gastric cancer incidence. So the cancer incidence is significantly increasing according to the atrophic grading. If the atrophic grading absent or close one, the percentage of the incidence of the gastric cancer is quite low. On the other hand, if the atrophic grade open 1 to open 3, severe atrophic gastritis, the possibility of the gastric cancer carcinogenesis is significantly higher. In routine endoscopy, how to observe the whole stomach is quite important for your daily clinical practice. Professor Yao proposed how to observe the endoscope. And he recommends at least 22 images should be taken during the routine endoscopic observation in the stomach, like this. And next, we have to know where we sometimes overlook the lesion. It is very important, the portion frequently to be blind, to be overlooked for the lesion in the endoscopic observation. Sometimes lesion in the cardiac or lesion at the posterior or greater curvature of the body, we overlook the lesion. And sometimes, if the lesion is located at the fornix of the greater curvature, we sometimes overlook the lesion. And the lesion at the bulbs near the pyloric ring, it is very difficult to observe. And we sometimes overlook the lesion. And please be careful during the endoscopic observation for this portion. I would like to show you the overlook cases from now. This is 1 year before cancer diagnosis. We cannot detect the lesion here. It is a little bit difficult. And in retroflex position, the posterior wall of the gastric angle is sometimes difficult to observe. So it is very important to know posterior wall of the gastric angle is sometimes difficult to observe. It is in straight position, in posterior wall of the gastric angle region is sometimes observed tangentially. It is, in this situation, lesion can be overlooked easily. And in retroflex position, it is hard to detect in the lesion. In this situation, please push a little bit more in the retroflex position, and the lesion can be recognized easily. This endoscopic image is 1 year after this endoscopic image. This region is SM3 cancer. Maybe here and here and here lesion is existing at this time, but we overlook at this time. And it is very important to know posterior wall of the gastric angle is sometimes difficult. And next, greater curvature is easy to overlook. In this situation, sufficient insufflation is very important. Sometimes the lesion behind the gastric hold can be overlooked easily. This is a 38 years old female patient. Yeah, we overlook in this endoscopic image. The amount of the air is inadequate, and we didn't suck such mucus or water. In this situation, it is easy to overlook. But if you insufflate little by little, yes, lesion behind the hold can be recognized easily. Yeah, this cancer is very advanced cancer. But so it is necessary to suck the mucus and water and please inflate and dilate the stomach. And it is easy to detect the lesion behind the hold. And this is a case of advanced duodenal cancer. Lesion is located in the anterior wall of the bulbs. The anal side of the lesion can be recognized only just a little bit here. But it is very difficult to detect the lesion. Yeah, in this situation, sometimes we observe the duodenum in the retroflex position, like this. So lesion can be recognized very easily. Or sometimes transparent food is very helpful to observe in this situation. But unfortunately, I did by myself 1 year before cancer diagnosis. Yeah, this is an endoscopic image of 1 year before cancer diagnosis. Unfortunately, I cannot detect the lesion in this image. So it is very important to observe. Sometimes we miss cancer, and it is very important where is easy to overlap. And after you detect the suspicious lesion, next characterization is important. Characterization include this lesion is neoplastic or non, or tumor border, or tumor depth. And in this situation, NBI magnification is quite useful. Professor Yao proposed the VS classification. Maybe this classification is very famous all over the world, and everybody knows this classification. And recently, our society modified this VS classification, and we made diagnostic algorithm for early gastric cancer. According to this algorithm, if you find some suspicious lesion, next step, please check the demarcation line. Demarcation line is a clear border. And if the lesion has demarcation line, next step, please check the microvascular and microstructural regularity. If the microvascular and microstructure is irregular, this cancer can be diagnosed as cancer. But if the microvascular and microstructure is not irregular, this lesion is non-cancer. I would like to show you one case. The lesion is located at the greater curvature of the anterior wall of the lower gastric body. Yes, here. It's a little bit difficult to detect the lesion, but using white light imaging, lesion can be recognized as slightly reddish and depressed area. But using NBI, it is much more easier because lesion is brownish. And using NBI magnification, lesion has demarcation line. Yeah, lesion has clear border using NBI magnification. This is the oral side. There is a demarcation line. And the next step, we have to check the microvascular and microstructure pattern. And the microvascular and microstructure pattern is irregular. And we can make diagnosis this lesion as cancer. And how about this lesion? Yes, lesion is located in the same area. Here, lesion is slightly whitish and elevated lesion. And this is NBI magnification image. According to the NBI magnification, as you can see here, there is a clear border. Yes, this region has demarcation line. But in the region, microstructure pattern is not irregular. It's regular, and there is no irregular microvessel. So this region can be diagnosed as non-cancer. And histologically, this region is intestinal metaplasia. And how about here? This region is also a little bit whitish area. Yes, there is a demarcation line. And the lesion, in the lesion, the microstructure is disappeared and the microvascular is irregular. And we can make diagnosis this lesion as cancer with high confidence. This is a report about the utility of NBI magnification of characterization of gastric depressed region. In this region, about 400 depressed regions were prospectively enrolled. Diagnostic accuracy of NBI magnification is significantly higher compared to white light imaging. And the diagnostic accuracy is highest in white light plus NBI magnification group. So we recommend we should make diagnosis for gastric region using NBI magnification and white light imaging in comprehensive manner. How about the detection of the early gastric cancer? This endoscopic image is the previous version of the NBI. Previous version of the NBI is quite dark, and it is difficult to detect the lesion using NBI non-magnification using previous version of NBI. But recently, Lucera Elite 290 series NBI is quite bright compared to the previous one, and it is very useful for detection of the early gastric cancer. Can you find the lesion in this endoscopic image? It is sometimes difficult, but this patient has scar, and this patient has severe atrophic gastritis. So in this situation, please be careful during the endoscopic observation. And using injibocalmine, it is a little bit difficult to detect the lesion. Maybe many doctors overlook the lesion using only this image. But in this situation, please push NBI button. Maybe everybody can detect the lesion at the gastric angle here, because the lesion can be recognized as brownish area. And as I told you, using NBI magnification, there is a clear border here. And if the lesion has demarcation line, please check the microstructure and microvascular pattern. And the microvascular pattern is irregular here and here, and we can make diagnosis this region as cancer. And next case, can you find the lesion? The lesion is a little bit difficult only using white light imaging, but the hole is enlarged and dirty mucus is existing and severe atrophic gastritis. This endoscopic feature is corresponding to H. pylori positive patient. And if you find such endoscopic feature during endoscopic observation, please be careful during the endoscopic observation in the stomach. But it is a little bit difficult only using white light imaging like this. But if you push the NBI button, maybe everybody can detect the lesion because the lesion is brownish here, here, maybe here. And using NBI magnification, as I told you, there is a demarcation line. Demarcation line is clear border using NBI. Here, there is a clear border. And if you find the demarcation line, next step, please check the microvascular and microstructure pattern in the lesion. And as you can see here, microstructure is irregular or obscure. And there is many irregular microvessel. Irregular microvessel means dilatation, tuberosity, and caliber change, and barrier shape. If you find such 4 characters, you please call such vessel as irregular microvessel. And if you find such endoscopic feature, you can make diagnosis this region as cancer with high confidence. And this one is also difficult to detect the lesion using white light imaging and chromoendoscopy with intraocular line. But using NBI, it's much more easier to detect the lesion because the lesion is brownish. And if the lesion has demarcation line, please check the microstructure and microvascular pattern. And the microstructure pattern is completely destroyed. And there is an irregular microvessel. And the irregular microvessel has a network pattern. So we can make diagnosis. This one is well differentiated adenocarcinoma. And recently, new endoscope is commercially available in Japan. 2 months ago, this is a GIF 1200 endoscope. This is ultra thin endoscope. The diameter of the endoscope is only 5.4 millimeter. And this endoscope can be inserted transnasally. Compared to transoral endoscopy, transnasal endoscopy is less frequency and severity of gag reflex. So in Japan, many screening endoscopy has been performed by transnasal endoscopy. But previous version of transnasal ultra-thin endoscopy, the quality of endoscopic image is not so good and dark. But the quality image of this new endoscopy is completely improved. This is the endoscopic image of this endoscope, new endoscope. Yeah, the quality of the endoscope is quite good. And using NBI, the NBI is also very bright compared to the previous version. Like this. Unfortunately, this endoscope doesn't have magnifying endoscopy, magnifying function, but microstructure can be recognized easily like this. Maybe in future, in Thailand, many screening endoscopy will be performed in transnasal endoscopy. In such a situation, transnasal endoscopy is one of the options. Yeah, because of the low invasiveness for the patient. Yeah, this is a summary of my presentation. I was talking about the risk factor of the gastric cancer. Yes, H. pylori is a very high relationship to the gastric cancer. And gastric atrophy grading is very important. And if you face to the patient with severe gastric gastritis, atrophic gastritis, please be careful during the endoscopic observation. And I'm talking about how to observe whole stomach. At least 22 images should be taken during the routine endoscopic observation. And next, I'm talking about the NBI and NBI magnification for early gastric cancer. First of all, please check the demarcation line. And if the lesion has demarcation line, next step, please check the microvascular and microstructure pattern. And this pattern is irregular. You can call this lesion as cancer. And finally, I want to say, please come to Japan and please come to our hospital, maybe next year. Thank you very much for your kind attention.
Thank you very much, Professor Kikuchi, about your excellent talk. So we have the question from the audience about the dye chromoendoscopy versus digital chromoendoscopy. Do you recommend to do routine dye chromoendoscopy, or just only digital chromoendoscopy is enough for gastric or esophageal cancer detection? And what is the difference between dye and digital chromoendoscopy?
Mm-hmm. Yeah, I think chromoendoscopy is necessary if you detect the lesion using white light endoscopy. I mean that not all patients I did not do chromoendoscopy, but maybe NBI I use for all patients. First I check the esophagus or stomach using white light endoscopy, and next I check using NBI. But not for all patients I do chromoendoscopy. If I detect some suspicious lesion, next I do NBI magnification, and finally I spray injuncalmine or iodine staining for such patient. But sometimes we omit chromoendoscopy recently.
Okay, thank you very much. So you recommend to do IEE or NBI routinely for the esophagus for esophageal cancer detection?
Yeah, maybe most of the doctors in Japan use NBI in the detection, in the screening endoscopy for esophagus and pharynx. I think, yeah, 100% we have to use.
One more question. They ask about how to differentiate IPCL from esophagitis and carcinoma, because most have the dilated IPCL.
Yeah, I think so. It's very good question. Yeah, sometimes it is very difficult to differentiate cancer and inflammation. But maybe cancer, the IPCL in the cancerous area have four characters, not only dilatation, but also tuberosity and caliber change and barrier shape. But in the IPCL of the inflammation, only dilatation. Such vessel has no character of caliber change or barrier shape. It is very big point. And the distribution of the IPCL is also important. In the cancerous area, the distribution of the IPCL is irregular. So please check the structure. And the next is the distribution of the IPCL, I think.
Okay, thank you. The next question is about the routine biopsy for the gastric cancer surveillance. If we cannot see any lesion in the stomach, do you recommend to do the routine random biopsy, and how many sites that you recommend if we need to do that?
We don't recommend random biopsy at all. First of all, we have to detect the suspicious lesion. And next, we do the NBI magnification observation. And finally, if we have the suspicious for the cancer, please take biopsy. In Japan, maybe no doctor do random biopsy for the stomach.
I agree to this recommendation from Professor Daisuke, because in the Western, they recommend to do random biopsy. But actually, if we can use the appropriate endoscopy or IEE, we do not need to do random biopsy. Okay.
Yeah, I think so.
For the next question, for the some area they don't have the magnified digital chromoendoscopy. So do you think that only demarcation line or the normal mucosa is enough to differentiate early gastric cancer from normal gastric mucosa? Just only use white light endoscopy is enough to differentiate this lesion.
Yeah, sometimes we are confused. This region is cancer or non-cancer, only using white light imaging, because both of them, cancer and erosion, is reddish and sometimes depressed. It is, I think it is sometimes difficult to differentiate cancer and inflammation in the stomach, only using white light imaging. I think NBI is necessary to make characterization. But NBI magnification, yeah, sometimes non-magnification is okay. If you observe using non-magnification, there is a demarcation line, and maybe only non-magnification, microstructure can be observed, but maybe microvascular is difficult to observe using non-magnification. So in this situation, please check the microstructure regularity, I think so.
Professor Daisuke,
yes.
Can I have the question on this answer for your question? Normally, nowadays, Olympus is commercially available for we call it the HQ series of the scope, which have the magnification, but it's only, I think it's 40 or something. It's the fixed magnification.
Yeah.
Is it enough for describe or differentiate looking at the microvascular for the upper GI? What is your opinion?
Maybe most of the case can be distinguished by HQ image. Yeah, 40 magnification, 40 times magnification. Maybe most of the case is enough, but sometimes there are difficult cases, especially for the case after eradication of H. pylori. Sometimes the diagnosis is very difficult. In this situation, high magnification is necessary. But most of the case, I think HQ endoscopy is enough.
Okay. And for the one who don't have the magnification scope, like they have only the high definition with the H or something, and what do you think if the practice, like we found the lesion that suspected the cancer, we just saw the demarcation line by the white light, or sometimes we have the small magnification with the HQ, and that area is suspicious, and we took the biopsy from that area, and by not so, because we don't have the enough equipment to do the fully detailed observation, just like that practice is, what do you think? Is this enough, or we should do something else? Because of for the upper GI lesion, we usually looking for the lesion, we do the biopsy, and we waiting for the pathologic study first to go further for the advanced therapeutic like the ESD or EMR. So what is the practice like this? Do you agree that is okay, or do we need to get the more equipment like the magnified scope or something like that?
Yeah, I think but you don't have a magnification scope, it's okay, I think. And if you observe using non-magnification, and I think demarcation line and microstructure is important for non-magnification. And using magnification, we can observe microvascular pattern. Microvascular pattern is very useful to distinguish cancer or non-cancer. But if you don't have magnification endoscopy, please check the demarcation and microstructure. And when you observe the microstructure, sometimes acetic acid is useful. Please spray acetic acid, and the microstructure can be observed very clearly. And the regularity of the microstructure, according to the regularity of the microstructure, you can make diagnosis this region as cancer or non-cancer.
Thank you.
You have answered the next question about the acetic acid for gastric cancer detection. So is it useful, right, to differentiate from the actual?
Yes. Sometimes it's useful, especially for the diagnosis of the tumor border. Yeah, sometimes we spray iodine, not iodine, acetic acid before the ESD. And some patient is useful, acetic acid.
Okay, thank you. For the NBI in the routine endoscopy, apart from the esophageal cancer detection, do you use NBI for screening early gastric cancer in the stomach? Do you recommend to do using the NBI?
Yes, I think so. There is a data from the randomized control trial to detection of the esophageal cancer. There is a data, but in the stomach, there is no data about the detection of the early gastric cancer. But in my experience, a new version of the NBI is quite bright, and it is very easy to detect the lesion, early gastric cancer, because the lesion is brownish. Sometimes we detect using NBI during the endoscopic routine observation. Yeah, maybe new type of the NBI is quite useful to detection of the early gastric cancer.
Okay, if you have the new version of the NBI, you can use it in the stomach as well.
Yes, I think so.
Okay. Any questions from the participant right now? Okay. If no question right now, I would like to give a break for 15 minutes to make Professor Daisuke for take some rest, because he had a long lecture for us this morning. So we will back at 10:40. Okay, 10:40.
Okay. 15 minutes later.
Yeah,
okay.
15 minutes. Yes. Thank you very much.
See you soon. Thank you very much for your kind attention.
Thank you. Thank you. For the next session, it will be endoscopic treatment for upper GI lesion.
Okay.
Okay, please stay tuned.